Now I'll talk about stroke. The commonest type of stroke that we see in 90% of cases is acute ischemic stroke. And in some questions, he can ask you like, what is the reason for development of the stroke in a patient? So the commonest variety of stroke, if he says overall the most common cause of acute ischemic stroke in a patient is, then it's an arrhythmia by the name of atrial fibrillation. To make it sound sophisticated, he will write like this, non-valvular. Because see, in India, we have rheumatic heart disease with mitral stenosis contributing to atrial fibrillation. So if it is rheumatic heart disease contributing to it, then we will say the word valvular atrial fibrillation. But in this question, we are using the word non-valvular atrial fibrillation for describing the infarct that is occurring. The patient is having sudden onset phase deviation. There is a arm weakness for the previous 3 hours and the CT scan shows a dense MCA sign. So if the patient will come early, we'll be able to see what is written at the moment as a dense MCA sign. But if a person will come late, like approximately like 6 hours later, then in our patient, they can be offending in the form of that hypodensity that is very much visible on the CT scan of a patient. So I said two things. If a person comes early, then it is a dense MCA sign if it's a large clot, and then subsequently a hypodensity can be seen. The main aspect is whenever it is going to be a brain hemorrhage will always be having a white area. But here, because there's an infarct, it is hypodensity. But I'm not going to wait for hypodensity to fully evolve and then say that it is a stroke patient. Like what I need to do for this case of acute ischemic stroke is I need to do a quick neuroimaging. The dole to imaging time should be kept under 25 minutes. DIT means dole to imaging time should be kept under 25 minutes. If the CT scan is normal, then the relatives will obviously trouble me, sir. How are you sure that my dad is having a stroke? Because features are matching, but then the person's query is a very genuine one, that how are you sure? So I can go in for a CT angiography. That's one another question where next investigation has been asked. Like in subarachnoid hemorrhage, I discussed next investigation 2 times with finding, without finding, but this time it is like clinical findings are there. CT scan is normal. What will you do next? It is a CT angiography. You'll be wondering what CT angiography will tell me. It will tell me about a large vessel occlusion. See, if it is a large vessel occlusion, then the contrast would not be going forwards. Like if it is involvement of the M1 part of the middle cerebral artery, or if it is a part of the middle M2 part of the middle cerebral artery getting involved, then the large vessel occlusion would be present. If he says what is the investigational choice for early detection of acute ischemic stroke, it is a diffusion weighted MRI. But MRI, one is expensive, facilities may not be available. CT scan is much more faster. So if he says what is the next investigation to be done, if CT is normal, answer is not diffusion weighted MRI, it is CT angio. The window period for management of acute ischemic stroke is within 4.5 hours. The upper limit is up to 6 hours, but if he says like ideally within how much time, like here I'm answering from the ideal perspective, like within how much time should the patient be treated, then the ideal perspective would be that we should be starting treatment within 4.5 hours for a case of acute ischemic stroke, though we can treat up to 6 hours. Lots of time he will not even ask you this much. He will just say, what are the priorities of acute stroke consultation? Your answer would be given as A, B, and C. A is understandable, secure the airway, because person's tongue can fall backwards and I don't want the airway to be compromised. B is not breathing. B is for the blood pressure value. If the blood pressure is more than 185 by 110 millimeter of mercury, then thrombolysis is absolutely contraindicated. I want to highlight the fact that thrombolysis should not be done. Obviously not in brain hemorrhage. Thrombolysis or fibrinolysis, like with L-teplase or with drugs like L-teplase or tenecteplase, do FDA approved drugs, thrombolysis is contraindicated if in a person the systolic blood pressure is more than the range that I have currently highlighted before you, despite treatment with medication. See, if the blood pressure will come down by giving nicardipine to the patient, or if the blood pressure will come down by using labetalol, I'm okay. But if the blood pressure is elevated, what will you do first? Will you thrombolyze? No, it will increase the risk of bleeding. So what you will do first in the patient is that you will have to manage the patient by lowering the BP, and the medicine that can be used to lowering the BP would be nicardipine. I'll write that also, but at the moment A is for airway, B is for blood pressure lowering, decrease the blood pressure to less than this threshold. I'm not saying decrease the BP to normal because I want to maintain brain perfusion now. So I'll decrease the blood pressure to less than 185 by 110. And C stands for clearly establish the time patient was seen normal. So speak to his wife, speak to the daughter, speak to the maid, because you want to know the exact window period for calculation. Because if person is coming in the first 6 hours, I will be using L-Taplis. But if person is coming after 6 hours, then I will be first doing a cerebral angiography. I will be doing a cerebral angiography in this particular patient so that I can identify no flow in a particular brain blood vessel. And then in the same setting, we can go in for deployment of a stent that will remove the clot in one piece. Look at the tech we have. We can be deploying a stent in the coronary artery that will grab that clot and we can pull it out in one piece. So we tend to call it a endovascular therapy. Instead of using the word endovascular therapy, I can also use the word thrombectomy. So the point to be understood is very simple, that when will you answer thrombectomy? If the person's thrombolysis, when you answer thrombectomy is when the patient is outside the window period of a thrombolysis. Here, additional point I want to say is that this point has been created to increase diagnostic utility, because when patient will come, like though clinically I know it is stroke, but I want to document it from the perspective that the case is not missed or is misdiagnosed. So he says that we should use a National Institute of Health stroke scale, and if the value of this is more than 5, then the patient is eligible for any of the 2 treatments that I'm mentioning. I mean, we are just trying to increase the diagnostic accuracy. And I've already highlighted that if the CT scan was normal, we can obviously do a CT angiography in a patient to document a large vessel obstruction for management of a acute ischemic stroke. As far as contraindications are concerned, the mnemonic for these contraindications is called as STORM. S would stand for sustained elevation of blood pressure. T would be from the bleeding diathesis component. If the international normalized ratio is more than 1.7, like person is on warfarin, I will not be doing thrombolysis. Then O is for the gastrointestinal bleeding component. Patient had a peptic ulcer bleed in the previous 3 weeks. I cannot give a new disease. No, suppose somebody had stroke and he had a peptic ulcer disease bleed also about 2 weeks back. If I do thrombolysis today, the thrombus in the brain will be destroyed, but the ulcer bleeding can start. The basic rule of medical science is first to no harm. You can't treat one disease and give a new one. So gastrointestinal bleeding. Then alphabet R is for like a recent head injury and cerebral hemorrhage. If you look at it, no, bleeding word is coming again and again. No, GI bleeding, intracerebral hemorrhage, recent head injury, that will also cause a bleeding in a patient. And then M is for a recent myocardial infarction, because patient could be on medications like warfarin that could increase the risk, or even aspirin, and that can, I mean, warfarin, the main drug, can increase the risk of bleeding in a patient. So STORM is a contraindication. As for sustained BP elevation despite treatment, mark my words there. Despite treatment, if the BP comes down, कोई tension नहीं है. If BP does not come down despite treatment, that is when we'll be using it. So the message here is, if any one of these are positive, if any one of these that I've currently described before you are present in a patient, then we need to be not doing thrombolysis. Then what will we do? We'll do a MERCY, or we'll do a thrombectomy. MERCY is the brand name, mechanical embolus retraction in cerebral ischemia. And indications are like pretty simple. Clinical diagnosis of stroke. Symptoms should be within 4.5 hours. CT scan should know hemorrhage or edema to greater than 1/3, because if it's a large infarct, no, then usually there is like a secondary hemorrhage occurring in a multilobar stroke. So we should restrict it to a stroke which is like limited to a particular area of the MCA territory. If it's like a huge infarct, then there's a risk of hemorrhagic transformation, and obviously the age of the patient should be more than 18 years of age, or contraindications for thrombolysis. Now, brain hemorrhage is where thrombolysis is not to be done. So I'll just highlight this again. Thrombolysis is indicated in. So we do it in a case of acute ischemic stroke. Thrombolysis is also done for cases of ST elevation MI that has been discussed in the cardiovascular system, and thrombolysis is also done in cases of massive pulmonary embolism. Thrombolysis is contraindicated. I'll just use English here. They gave a CT scan of a person having a brain hemorrhage, and they said what is not to be done in a patient. So it was a very funny question. Brain hemorrhage is visible. I know the side effect of these drugs. I mean, one of the biggest side effect of this particular drug is risk of bleeding. And by bleeding, I don't mean like bleeding from the nose or bleeding in or blood in the urine. I'm talking about serious central nervous system bleeding in a patient because of the risk effect or side effect of bleeding. In this case, hemorrhagic stroke, thrombolysis would be absolutely contraindicated. We don't do thrombolysis in a non-ST elevation myocardial infarction because it's a platelet-rich clot. I've already explained that in the cardiovascular section. We will not be using it in plain pulmonary embolism. For massive pulmonary embolism, thrombolysis is in, but for plain pulmonary embolism, it is heparin or enoxaparin that is sufficient for diagnosis. Then I've explained to you those storm situations where storm is valid for AIS. If person of acute ischemic stroke is presenting in the first 6 hours and any one of the storm is present, like sustained BP elevation despite treatment, bleeding diathesis is present in a person, or like gastrointestinal bleeding in the previous 3 weeks, recent head injury or recent myocardial infarction, AIS in the 6 hours, don't do thrombolysis, then you will trach up the patient in the cath lab and you will be doing a thrombectomy for management of these patients. Do not do thrombolysis in acute ischemic stroke if anyone from the storm is present. The reperfusion vision window for ST elevation MI is 12 hours. We can do thrombolysis up to 12 hours. But here, as I've explained to you, ideally it should be 4.5 hours. Upper limit if it says is 6 hours. So do take care of the fact heart is more resistant to hypoxia as compared to the brain. And if it says golden period for myocardial infarction, then it is usually within the first 1 to 2 hours, I can say, because of the increased risk of myocardial infarction.